I want you to picture the human body for a second. Not just as a biological machine, but more like a crime scene waiting to happen. We're talking about a major event, a life-threatening cancer that's sort of in the planning stages. But the thing about this specific culprit is it almost always leaves clues.
But they're hidden in plain sight.
Exactly. They aren't where you'd expect to find them.
Right. You're looking for a tumor in the kidney, but the real clue is, I don't know, a tiny bump on the chin or freckle on the lip.
Precisely. And that's what we're diving into today, hereditary cancer syndromes. And before we even get into the detective work, we have to talk about the sheer scale of this. The source material from radiographics drops a statistic at the top that, just sets the stakes. 10%.
10% of all cancers are hereditary.
Which might sound small if you say only 10%, but if you think about the global number of cancer diagnoses, that is a massive number of people.
It is.
And the scary part is that a huge chunk of these just go undiagnosed until it's way too late.
And that's the real tragedy of it. Because when we miss a hereditary diagnosis, we aren't just failing the patient in the room.
No.
We're failing their kids, their siblings, their parents. Most of these syndromes we're going to break down are autosomal dominant.
Okay, let's pause on that term because it's so important. Autosomal dominant.
Think of it like a coin flip. If you have the gene mutation, there is a 50% chance every single time you have a child that you pass it on.
It doesn't skip generations.
It doesn't skip generations.
Yeah.
So if we spot a pattern in you, it triggers this whole cascade of prevention for your family. It turns a diagnosis into like a family rescue mission.
So that's our mission today. We're going to be medical detectives. We'll scan through the abdomen and pelvis, but we're going to keep our eyes locked on those weird extra abdominal clues. And we're starting in the gut,
The polyposis syndromes.
where multiple is the key word.
And the grandfather of them all is familial adenomatous polyposis, FAP. This is the one most people learn first because the imaging is just, it's undeniable.
And when we say polyps here, we're not talking about one or two you might find during a routine screening.
Oh, no, not at all. We are talking hundreds, sometimes thousands. The source actually describes the colon as being carpeted with these polyps.
Carpeted. That visual is just visceral. A wall-to-wall carpet of potential trouble. And the risk profile here, it's absolute, isn't it? It's not a you might get cancer situation.
Correct. If you do nothing, the lifetime risk of colorectal cancer in FAP patients is, for all intents and purposes, 100%.
100%.
And it happens early. The average age for cancer is around 39.
Which explains the really radical management. We're talking prophylactic total colectomy.
Removing the colon entirely, often when these patients are in their late teens or early 20s.
It's a life-altering surgery to prevent a life-ending disease. But here's where the detective work gets really interesting. There's a variant of FAP called Gardner syndrome.
Right.
Same carpet of polyps, same cancer risk, but you also get this whole grab bag of strange physical traits that show up outside the gut.
And often before the gut issues, which is why they're so valuable. You might see osteomas. These are benign bone growths, but they love to pop up on the skull and the jaw.
So you could literally be at the dentist getting a panoramic x-ray, and they spot these growths on your jaw.
And not just growths, supernumerary teeth.
Extra teeth.
Extra teeth. I mean, imagine that conversation. So you have too many teeth and some bone growths here.
Yeah.
You need to see a gastroenterologist immediately.
It sounds totally absurd, but that connection saves lives. It points to a mutation in the APC gene.
Which is the gene that's supposed to regulate cell growth. It's the why behind all of this. If the brakes on cell growth are cut, you just get too much tissue.
Too many cells in the colon become polyps, too much bone becomes osteomas.
Too many teeth. It's the same error just playing out in different parts of the body.
The source also mentions desmoid tumors. These sound incredibly difficult.
They are the bane of a FAP patient's existence. A desmoid is a locally aggressive mass of fibrous tissue. In the general population, they're really rare. In FAP patients,
What's the risk?
the risk is increased 1,000-fold.
1,000. Wow.
And they are nasty. They infiltrate everything. They wrap around blood vessels like concrete. And the cruelest part is they're often triggered by trauma, including surgery.
Wait, so the surgery to remove the colon to prevent the cancer could actually trigger one of these tumors?
It is a terrible, terrible catch-22. You save them from cancer, and the surgical trauma itself might spark this desmoid that becomes this chronic, unclimbable mountain.
Okay, let's pivot to another polyposis syndrome. Peutz-Jeghers, or PJS.
This one is also autosomal dominant, but The clue was right there on the face. It's called mucocutaneous pigmentation.
Which is a fancier way of saying freckles.
Specific freckles. Dark blue-brown spots on the lips, the gums, inside the cheeks. About 95% of PJS patients have them.
So if you see a kid with those distinct lip spots, you need to be thinking about their small intestine. But the polyps aren't the same carpet as FAP.
No, these are hamartomatous polyps. So think of a hamartoma as just a disorganized overgrowth of the tissue that's supposed to be there. It's not precancerous like an adenoma. It's just a messy clump of normal cells.
So is cancer the main worry then?
Cancer is a worry down the line, sure. Colon, stomach, pancreas. But the immediate danger is mechanical. These polyps get big, and they grow on stalks. And since they're in the small bowel,
The bowel just grabs it and pulls.
exactly, it's called intussusception. The bowel telescopes inside itself, cuts off the blood supply. It is an acute surgical emergency, and it happens in up to 70% of these patients.
So the spots on the lips are a warning sign for a bowel obstruction.
Wow. Okay, next up, one that I think the name confuses people, juvenile polyposis syndrome.
Right, and the term juvenile refers to the type of polyp, the histology, not necessarily the age of the patient. Though, to be fair, most of them do get polyps by age 20.
And like Gardner syndrome, there are other physical traits here.
Yes, that same kind of overgrowth theme. You see things like macrocephaly, clinically large head, cleft palate, polydactyly, extra fingers or toes. It's a recurring theme, isn't it? Extra teeth, extra fingers, overgrowth of polyps. It's like the stop signal in the genetic code is broken.
That's precisely what it is.
Okay, let's shift gears. We've talked about syndromes where the gut is crowded with polyps, but what about the hidden ones? The syndromes where the colon might look normal right up until it's too late. I'm talking about Lynch syndrome.
Lynch is the most common hereditary cause of colorectal cancer. It used to be called HNPCC, hereditary non-polyposis colorectal cancer. And that name was actually pretty helpful.
Because it tells you what not to look for.
Exactly. You won't see the carpet of polyps. The cancer just appears. And it appears early in your 40s or 50s. And it has a distinct pattern. It loves the right side of the colon.
Why does that location matter so much? I mean, a tumor's a tumor.
It matters for detection. Think about a flexible sigmoidoscopy, the partial scope. It only looks at the left side. If you use that to screen a Lynch patient, you will miss the tumor 100% of the time.
That is terrifying.
It is. It's hiding over in the cecum on the right side. That's why a full colonoscopy is non-negotiable if there's a family history.
And what's the big extra abdominal clue for Lynch, especially in women?
The seminal cancer in women is often endometrial cancer. The risk is huge, up to 54%. In many, many cases, a woman will get uterine cancer years before the colon cancer ever shows up.
So a diagnosis of endometrial cancer in a woman in her 40s, it's not just a gynecological issue. It should trigger the question, is your colon at risk?
It has to. And ovaries, too.
Speaking of hidden threats, we have to talk about hereditary diffuse gastric cancer. The CDH1 mutation, reading about this one was genuinely unsettling.
It is a very heavy diagnosis. The term to remember here is lenitis plastica.
The leather bottle stomach.
That's the one. Most stomach cancers form a lump, a mass you can see. This one doesn't. It just infiltrates the wall of the stomach diffusely. It makes the wall thick, rigid, like a leather bottle.
And because there's no lump, you can't see it on an endoscopy until it's very advanced.
Exactly. You can be looking right at the stomach lining, and it might appear normal, but the cancer is spreading just underneath.
And there's a breast cancer connection here, but a specific one.
Yes, lobular breast cancer. Not the more common ductal type. If you see a family with diffuse stomach cancer and lobular breast cancer, alarms should be going off.
And the prevention, it's just so radical.
It is. Because screening is so unreliable for this, the recommendation for CDH1 carriers is often a prophylactic total gastrectomy.
Removal of the entire stomach.
Usually in their 20s or 30s.
That is just a profound decision for a young person to make. You're trading your digestive normalcy to guarantee your life.
You are. But without the surgery, the mortality rate is incredibly high. It really highlights the burden of these mutations.
Let's move geographically now. We're leaving the gut, heading to the kidneys, the renal syndromes, and there's one that seems to affect almost every system. Von Hippel-Lindau, VHL.
VHL is the classic multi-system disorder. It's a defect in the VHL tumor suppressor gene. When that's offline, tumors can grow everywhere. Eyes, brain, spine, pancreas, and the kidneys.
And the kidney risk is the big killer, right?
A clear cell renal cell carcinoma. About 40 to 70% of VHL patients will get it. And unlike sporadic kidney cancer, These tend to be bilateral, both kidneys and multifocal, so many tumors in each kidney.
I love a smoking gun clue. And the source mentions a sign in men that is pathognomonic, meaning if you see it, it's game over. It's the diagnosis.
You're talking about the bilateral papillary cystadenomas of the epididymis.
Which is a mouthful. Break that down.
Okay. The epididymis is the coiled tube on top of the testicle. In VHL, men get these benign cystic masses there. If you see them on one side, okay, maybe it's just bad luck. But you see them on both sides, it is a virtual guarantee they have von Hippel-Lindau.
So you could be doing a scrotal ultrasound for pain or something. You see these bilateral masses, and suddenly you know you need to scan this guy's brain and kidneys.
That is medical detective work right there, pulling a thread in the pelvis that unravels a mystery in the brain.
Next up is tuberous sclerosis, TS. On imaging, we see a triad of kidneys, lungs, and brain.
In the kidneys, we look for angiomyolipomas, AMLs. The name tells you what's in them. Angio, vessels, myo, muscle, and lipoma, fat.
And fat in a kidney tumor is usually the giveaway that it's benign.
It is. But in TS, these AMLs get huge, and they're everywhere. And the danger is in cancer. It's that they can explode.
Explode.
They're very vascular. If they get bigger than 3 or 4 centimeters, the risk of spontaneous hemorrhage bleeding goes way up. It can be life-threatening.
And the lung connection. This affects women mostly.
Yes, a condition called LAM, lymphangioliomyomatosis.
Glad you said that one.
It's a mouthful. Basically, the lung tissue gets replaced by cysts. On a CT scan, it looks like Swiss cheese. The lungs get really fragile.
And that leads to collapsed lungs.
Spontaneous pneumothorax. So, picture this. A young woman comes into the ER with a collapsed lung. You get a CT. You see the cysts. Your next move shouldn't just be fixing the lung.
You have to connect the dots.
You had to look at her kidneys for AMLs, check her brain for cortical tubers. You had to put the whole story together.
There's one more kidney syndrome that links the skin and lungs in a unique way. Birt-Hogg-Dubé.
Right, Birt-Hogg-Dubé. Here, you also get pulmonary cysts and collapsed lungs. But the cysts look different. They're more irregular, and they tend to be at the bottom of the lungs.
And the skin sign.
Fibrofolliculomas. Pale, dome-shaped bumps, usually on the face and neck.
And the kidney tumor flavor. VHL was clear cell. What's this one?
This is important. In BHD, the tumors are typically chromophobe, renal cell carcinoma, or oncocytomas. Generally less aggressive than clear cell, but you still have to catch it.
It feels like skin bump plus kidney problem is a recurring theme here.
It's embryology. The skin and parts of the urinary tract often share a developmental origin. So when the genetic code is buggy, the error prints out in both places.
It's an error in the original blueprint. That brings us to our final section. The dermatological and metabolic clues. Let's talk about Cowden syndrome.
Cowden syndrome. We see macrocephaly again, the large head size, and the skin finding is tretalomomas.
Which look like little wart-like growths around the mouth, nose, and ears.
Exactly. And if you have Cowden's, you're at high risk for
breast cancer, right?
Breast cancer, the big one, up to 50% risk. But also thyroid cancer, the follicular type, and endometrial cancer.
There was one really random but fascinating imaging clue for Cowden's. It was in the esophagus.
Ah, yes. Glycogenic acanthosis.
What is that?
On imaging, you see these white plaques lining the esophagus. It looks like cobblestones. In a normal person, seeing 1 or 2 is fine. In Cowden patients, the esophagus is just covered in them.
So, white spots in the throat plus a large head equals check the thyroid and breast.
That's the formula.
Finally, let's touch on a syndrome with a very long name and a very aggressive nature. Hereditary leiomyomatosis and RCC.
HLRCC. This one is scary. So leiomyomas are smooth muscle tumors. Patients get them on their skin, and the key is that they are painful, sensitive to touch or cold.
And they also get them in the uterus, uterine fibroids. But fibroids are so common.
True. But in HLRCC, women get them very young, and they are massive and multiple. We're talking women needing hysterectomies in their early 20s because the symptoms are unmanageable.
And the RCC part of the name, the kidney cancer.
Yes, and this is crucial. The type here is fumarate hydratase deficient RCC. And it is incredibly aggressive. Unlike the others we've discussed that might grow slowly, this one metastasizes early. It can spread when the primary tumor is still tiny.
So this is absolutely not a watch and wait situation.
Absolutely not. If
No.
you see that pattern, painful skin bumps, severe early fibroids, you have to be surveilling the kidneys like a hawk. Catching that cancer early is the only way.
Okay, let's try to synthesize all of this. We've gone from carpets of polyps to spots on lips, lung cysts, extra teeth.
It's a lot of information, I know. But the underlying message is just about pattern recognition. These are multi-system disorders. You cannot view an organ in isolation.
It really feels like the radiologist is the gatekeeper here.
They're the early warning system. A dermatologist sees the skin, a dentist sees the jaw, but the radiologist is often the only one who sees the abdomen and the lungs and the bones on a single scan. They're positioned to say, hey, this lung cyst and this kidney tumor aren't two separate unlucky events. They're one genetic story.
And recognizing that story is what triggers the genetic testing.
Which changes everything. It moves medicine from being reactive, treating cancer when it shows up, to being proactive. We scan the families, we catch things early, we save lives.
It just brings me back to that 10% statistic from the beginning.
Right.
And I have to leave our listeners with this thought. How many cases that we currently label as bad luck or sporadic are actually just undiagnosed syndromes where we all miss the clues?
That's the question, isn't it? And as our imaging gets better and our genetic understanding deepens, I suspect we're going to find that number is actually higher than 10%. We just haven't been good enough detectives yet.
Well, hopefully, after this deep dive, we're all a little better at spotting those clues. Thanks for listening.
Stay curious.